Good afternoon and welcome to today's presentation, Transforming Data into Information Using Standard Quality Measures, Part 2. My name is Kaylin Henderson and I'll be your facilitator today. At this time, all attendee lines are muted to eliminate background noise and distractions. We encourage your questions and input throughout this presentation, so please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation is being recorded and later uploaded to our YouTube channel. Our PDSA member for Delaware Health Information Board on DIN for 5 years. As a master's business administration, is passionate about healthcare and patient outcomes. Our second speaker today is Edward Sybil, DO. Dr. Sybil is Health Vision Delmarva's PTN medical advisor. Dr. Sybil is also a retired family physician from the Family Practice Associates of Wilmington, Delaware. He is the medical director of the Healthcare Quality Improvement Program for Quality Insights of Delaware, a state quality improvement organization. His areas of expertise include quality improvement, evidence-based medicine, practice management, and electronic medical record system implementation. Dr. Sybil is a senior attending in the Department of Family and Community Medicine, Christiana Care Health System, Wilmington, Delaware. He is board certified in family practice after graduating from the University of Health Sciences College of Osteopathic Medicine in Kansas City, Missouri in 1973, and completed an internship at Parkview Hospital in Philadelphia, Pennsylvania. His awards include the 2001 Family Physician of the Year by the Delaware Academy of Family Physicians. He was a finalist for the 2010 HIMSS Nicholas E. Davies Award of Excellence for recognized excellence in implementation and value of health information technology. He received the 2011 Daniel A. Alvarez MD Service Award from the Medical Society of Delaware for helping implement over 1,000 positions on electronic medical records. And he currently serves as a precipitator for the Department of Community and Health Medicine Regency Program. I'd now like to thank both of our presenters for their time today, and I'll pass it over to Barb to start with our learning objectives.
Thanks, Kaylin. Good afternoon. This is part 2. Last week we had part 1 of transforming data into information using standard quality measures. Our learning objectives for this part 2 session is to have a clear understanding of your quality measure scores and determine if the measure scores represent how well you think your practice is doing. I go into a lot of practices and we look at their quality measures and they said, this can't be right. This number, I mean, we know that we have a lot of patients that have their blood pressure under control. So we're going to actually take a look at these measures and actually hopefully make sure that we get the number that you guys really are doing. The second one is review processes to help your practice improve your measure scores and understand tools which can be used to help your practice improve their 2017 MIPS score. The agenda today, I'm going to start off and we're going to have talk about a clear understanding of quality measures. It's a kind of a continuation of part 1. And I'm going to then turn it over to Dr. Sobel for physician leadership in improving quality measures. And he'll turn it back to me and say processes to help your practice improve your measure scores. We're going to use one familiar quality improvement technique. We're going to use the quality improvement process, Plan, Do, Study, Act, to resolve any issues as we go through looking at these scores. And the second thing would be use patient engagement to improve your scores. That's near and dear to my heart. You have to get the patient involved. And the last but not least is tools which can be used to help you practice and improve their 2017 scores. So let me start off. Understanding, and this is kind of a repeat from the first session, but understanding your quality measures. I don't know how many people look at their measure specification sheet, but you need to get very, very familiar with that. I have pulled out 6 different items that are really important when you're looking at your measure scores. You want to look at the description, which is a brief narrative description of the measure. You want to look at the denominator. What eligible cases for the measure, including the population, patient population, and or patient demographics. You want to look at denominator exclusions. Certain populations may be excluded from the measure. For example, a lot of times population the numerator quality measures have a designated time frame when the measure should be completed. For example, your flu shot. There's only certain months that actually you can record that measure.
I'm sorry to interrupt you. I'm getting a lot of people saying that they're having some audio issues. I'm trying to...
Okay, if you're still having problems, please send your message over to Caitlin. So, here's a couple examples. I have 2 examples of quality measures. 236, number 236, quality ID, controlling hypertension. The description on this is percentage of patients 18 to 85 of age who had a diagnosis of hypertension and whose blood pressure was adequately controlled. In other words, it was less than 140/90 during the measurement period. The denominator would be patients 18 and 85 of age who has a diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period. So the denominator criteria is basically anybody on the date of the encounter and has a diagnosis of hypertension, and that's the code for hypertension, and patient encounters during the performance period. Okay, the reporting frequency there, this measure is to be reported a minimum once per performance period for a patient with hypertension seen during the performance period. Okay, excuse me, I'm going back to the previous slide. Denominator exclusions, hospice services given to patients anytime during the measurement period. So, of course, the hospice patients would be excluded, and patients that have end-stage renal dialysis, or in this case, pregnancy cases. The numerator would be patients whose blood pressure at the most recent visit is adequately controlled, 140/90, less than 140/90. And again, I talked about the reporting frequency, once, at least minimum once per performance period, and it should be the performance period is this measure for 12 months. Another example, I'm not going to go into all that detail. You see a lot of detail ICD-10 codes, but it's really, this deals with diabetes. And this particular measure is, you want it to go down instead of up. These are percent of patients 18 to 75 of age with diabetes who HbA1c is greater than 9 during the measurement period. The denominator would be anybody who has diabetes with a visit during the measurement period. And they get very specific, and any kind of person who has that diagnosis code would be included. Patient and actually the patient who had a encounter during that period. The exclusion, again, would be the hospice services would be excluded from this measure. Again, the numerator would be anybody who has performance greater than 9. And I really want you to take a look at this one because a lot of practices are reporting, I shouldn't say a lot, a few practices are reporting 100%. And when you report 100%, this means that every patient that comes into your office has an A1C over 9. So you need to understand the measures and make sure, most of the time 100% would be great. But this, again, is an inverse measure. Reporting frequency, this measure is to be reported at a minimum once per performance period for patients who have diabetes. And again, the timeline is 12 months. Okay, I'm going to turn it back over to Kaylin for a polling question.
Before we do this one question, I'm going to switch to computer audio. I can see a couple people are still having some issues hearing us. Was better, and if you guys can just put in the chat box that you guys can hear me, that would be fantastic. Now launch our first polling question. Great, good. Thanks for the feedback, guys. First polling question: do you have a thorough understanding of your MIPS measures that your practice is collecting? Yes, I understand my measures and can accurately capture them. No, I do not understand my measures or how to capture them. Or I understand my measures, but I do not know how to capture them. Thanks, everyone, for that feedback on the audio. I'm going to go ahead and close that poll, and I'll share those results. It looks like we had 73% say yes, they understand the measures and can accurately capture them. 9% said no, they don't understand or how to capture them. And 18% saying they understood, but still don't know how quite to capture them.
Well, I would ask that anybody who's working with Health Visions Delmarva to actually work with their practice advisor, because this is really important to make sure you know how to adequately capture that data in your EHR. Because again, if you don't have accurate information, it's not going to report what your office is really doing.
All right, Dr. Silva, I'm going to give you keyboard and mouse control.
Okay, good. We need to talk a little bit about physician leadership in improving the measures. The first question, in order for a practice to be successful, is the question, is your practice leadership committed to improvement? And this needs to be a resounding yes. If leadership is not committed to delivering the best care possible, then we're all wasting our time on this deal. And so it's really important that we get top-down care or agreement on this. So why do practices, why do clinicians reject the opportunity to improve? And I've put a couple reasons down here. The doctors are already overwhelmed with patients, and we're going to go through some of the rationale of this. All of my patients are under good control. Obviously, all of my patients over 50 have had a colonoscopy. All my women who are eligible have had a mammogram, and none of my diabetics have a hemoglobin A1C below or above 7. So this is what I'll often hear. Physicians will say, I don't have time to take for this. I'm too busy. So I just don't want to be messing around with this. Another one is I want to take care of patients. As my partner used to say, my mama didn't send me to medical school to take care of an office. I went to school to learn how to take care of patients. And another one is all this is theoretical. It's nice, it's cute, but this is not what I need to do. We're doing good enough already. Kaylin, it's not going down to the next slide, so if you can move it for me.
Sure, absolutely.
Okay, so let's look at the answers to those questions. Our clinicians are already overwhelmed with patients. No doubt about that. Offices report being overwhelmed, and studies do indicate that demand will be increasing. Everybody agreed that when the ACA came in, there would be patients suddenly with insurance who were showing up at offices rather than showing up at the emergency room. The question really to ask is whether the clinicians are effectively using their time and resources. So for example, offices often run on a standardized fixed methodology. Oh, all my diabetics need to be seen every 6 months unless they're unstable. But really the question becomes, do you really need to see a patient, for instance, whose hemoglobin A1C is consistently under 7 milligrams %? Do I need to see them every 6 months? Could I see them once a year? Could I see them less frequently? Can I do something differently to take care of them? Next slide. All of my patients are under good control, and I hear this all of the time. Well, my response to that is not every patient in your practice is under good control. If you dig in the corners, you can certainly find them. If you do reports, you'll find them. Patients are there. The patients who are under poor control often don't show up. They're embarrassed. They know they're not doing well, and they don't come. It's sometimes like a child who knows they're being bad. They're just not going to show up and tell you that they're doing bad. Now, on the other hand, physicians tend to be very data-driven. All of us are type A personalities. When you listen to physicians talk, they will always talk about, percentage odds. What are the percentage odds that this treatment will work? What is the percentage of this? What percentage of patients get better? What's the percentage drop if I use this medication? So physicians tend to be very data-driven. We grow up in this. So if we have data, we can tell if a statement of all of my patients are under good control is indeed true or not. Another one that I'll hear often is insurance company data is always wrong. It's just a waste of time to look at all this data because it's always wrong. And my response to that is I agree with you 100%. Very often insurance data is completely wrong for any variety of reasons. But if you're getting the data internally from your own data source, which is your EHR, you can certainly see what percentage of patients are out of control and identify who they are, and then begin to focus on the patients that really need clinician help. Next slide. I don't have time for this. I'm too busy. And that's true. As I said before, most physicians really don't want to get into the nuts and bolts of back office stuff like generating reports. There's people like me who like it and had misspent their youth and adulthood playing with computers and software and stuff like that. But most physicians really don't want to get involved in that. They want to see the data. But if the physicians exhibit leadership commitment, if the practice management exhibits the commitment, the practice can help patients better control with little or no diversion of clinician time from taking care of their patients. Back to the statement before, my mama didn't send me to medical school to run a computer. She sent me there to take care of patients. So if we structure a quality improvement program that really does not require the physician to be sitting in front of a computer trying to generate reports, if all this comes in the background but is presented to the clinicians, we really will move further ahead on this and can move further ahead. Next slide. I just want to take care of patients, not manage the office. Absolutely. When you think about it, your resource of your clinicians are the people who actually generate the income for the practice. They should be seeing patients. They should be taking care of patients. Most physicians want no part of running an office. most of them hate it, which is kind of why they all go into these big groups, or they work for the hospital, or do whatever they can. They don't want to do the back office work. So if we can set up a system whereby the clinician time is focused on helping their patients who are most in need, we really fulfill a basic goal of the practice to improving the care of the patients that you serve. Next slide. This is all theoretical. We're doing good enough. Too many offices have the assumption we're just going to grind them out. We're in a fee-for-service world, and as long as we're seeing patients, the more patients I can see per day, this is the way it's going to work. And the answer to that question, as you certainly started to hear, is fee-for-service is going away for Medicare. MIPS has started. Now, MIPS will constantly say 2019 as the start of MIPS, but MIPS is really starting this year. What's done this year on behalf of MIPS, if you want to look at it that way, based on the quality of care that you're delivering and not just grinding out visits, is going to impact a reimbursement in the future. If you don't have the data, your reimbursement will fall. Ignoring quality care, ignoring MIPS, saying, you know what, this is all nonsense, I'm just going to keep grinding these patients out, ultimately could represent a up to negative 9% adjustment for Medicare in a few years. On the flip side, just to be positive about it, paying attention could result in 9% upswing in reimbursement for Medicare in a few years. Another comment that you'll get is, oh, well, this is Medicare. They're just a pain in the neck, and I'll just put up with it, or I won't see any Medicare patients. I'll just go in my fee-for-service world. History has shown us conclusively and overwhelmingly that once Medicare figures out any bugs that are in there or shows that a program works, the private insurers will always follow suit and begin to do exactly what Medicare does. Next slide. Okay, so practice leadership can change practice. I make this akin to a general leading an army into war. The general doesn't necessarily have to be up there in the foxhole loading his rifle and shooting at the bad guys coming across, but the general's got to be there, has got to be supporting. If the staff sees that there's no interest in quality care for management, they get the message. If the general is back playing golf with the president at Mar-a-Lago while there's a war going on, those in the foxholes clearly see what's going on and get a message. So leadership, clinicians in the practice, and other management need to really take a, and I know I've picked on physicians, but that's kind of where we are. And but any kind of leadership in the office, physicians really need to lead in supporting and encouraging quality care, supporting office transformation, even if they don't have the direct input. So they don't necessarily need to be sitting there on a day-to-day basis. The doctors do need to support the data collection that's out there. They need to review the data and use it to give direction to the staff. Remember, physicians are driven by data. When you show your physicians, your practice, that the data is not nearly as good as they think it is, or looking at it a different way, can be made better, maybe you're up in a 90% range, but can we get to 95% or more? So, but when clinicians begin to see data and they begin to see comparative data, which is really what's coming down the road, they're going to look they're going to see not only their own practice but other practices. It's a real driver. So the encouragement is get practice leadership to lead the change. Get the general to lead the change. Next slide, Caitlin. Brings us to our polling question.
Your second polling question is, how involved is your physician or designated clinical champion in participating in Health Vision Summary transformation initiatives? Very involved, participates in most of the meetings, never involved and does not participate in any of the meetings, only involved in the practice manager needs a clinician's view, or the manager keeps the physician updated and shares physician's views. About 63% voted. Give it a couple more seconds. I'm going to close that poll and I'll share those results. We had 27% say very involved. Participants enjoyed most of the meetings. 13% said they're never involved and doesn't participate. 33 said only when the practice manager needs the clinician's view, and 27% says the manager keeps the physician updated and shares physician views. Dr. Sable?
Okay, I had to put myself back online again. Yeah, that's interesting. A lot of the physicians are, involved in this or management, whichever way you want to look at it. But it's really the critical view. So for those who are down there in the percentage of no physician involvement or no management involvement, we need to get them to move on, see why we can't get their participation, however we define it, improved.
Thank you, Dr. Shallow. I'm going to pass this back over to Barb.
Caitlin, just to let you know you're echoing. I don't know why.
Okay, let's see if Barb echoes.
Okay, just an added point of view on that polling question. I would like to offer that Dr. Sobel's available for any practice that really wants to get their physician involved in doing this practice transformation. I have used him quite often, and he has a conversation with the physician, and basically, usually, they become very involved. So, my next, as a practice, what can you do to improve your measures? Well, are you producing reports out of your EHR? I mean, a lot of times we walk in and a lot of practices don't produce those reports. Reports should be produced at a minimum on a quarterly basis. Look at the percentages and ensure that it is either improving or it's at least staying the same as the last quarter's percentage. If the percentage is not improving, going up and down, depending on the measure, then look at your processes of documenting the measures in your EHR. Use Plan, Do, Study, Act. Again, it's a quality improvement process, and we've been working with a lot of practices, and you guys probably all know this by now. Well, plan, look at your measures that you are having difficulty with, and go into the definition of the measure that is on QPP site. Again, that's those specification measures, the definition of the measures. Ensure you understand the measure and the exclusions of what is not being reported in the numbers, the numerator and denominator. Ensure you understand that is what is being reported in the numerator and denominator, and call your EHR vendor and make sure you are documenting the data in your EHR correctly. I will tell you that we have had a lot of practices, not a lot, a few practices where their EHR vendor didn't program the specific measure correctly, so it didn't matter whatever they would put into their EHR, it just wasn't producing correctly. Once you understand the quality measure and how you should document the measure in your EHR, implement a process to ensure that a clinician is entering the data. On the next sheet, on next screen, I will have a chart, and on this chart, you need to indicate who's accountable for entering that data. Review a daily report to ensure that the data is entered correctly. If not, educate the accountable person and have the person correct the documentation in the record. Here's the chart here. It's how the data should be captured. You should, on the left-hand side, you should identify the measures that you're collecting, the name of the field in EHR to be completed, and the content required in the EHR to count as a positive result. So a lot of times for BMI, the system actually counts the BMI, and it actually looks at the height and weight and automatically counts the BMI. So that's a positive result. Accountable person or physician responsible to enter that data, in that case, it would probably be the medical assistant. But at least you know who's accountable for that, so when you go back and information or the measures don't look good, then you know who to go to. Study, on a monthly or quarterly basis, produce your measure reports out of your system, showing your measure scores. Are there improvements in your measure scores? If the measure scores are not improving, produce a specific list of patients who qualified in the numerator for this measure. Now again, you have to go back to the specification sheets and actually pull a report by you putting in their ICD-10 code or CPT code. Review each patient's electronic health record and see how the measure was documented. A lot of times it's not documented in the right field, and one medical assistant person may be putting it in the correct field and one may not. Act. See if there are common issues with those records which are not documented correctly. Are the reports that are produced out of your EHR producing accurate information? Again, if you've done all this and it's not reporting accurate information, then you need to call your EHR vendor. Are there clinicians who are responsible to document the requirements for that measure, who are not entering it or not documented in the designated field? If that's the case, you need to sit down and re-educate that clinician. Repeat the process on a monthly or quarterly basis until the measures are at the percentage where you feel your practice should be. Physicians and other providers should discuss these measures and look at ways to improve the measure scores, which will improve patient outcomes. And the reason why I say this one, and we'll get into patient engagement, again, I talk to a lot of physicians and they say, well, if my patient doesn't listen to me, why should I have bad scores? Well, there's got to be ways to get the patient to listen to you and hopefully do things that you want them to do. Now we're going to move into patient engagement to improve your score. Use an e-tool, a patient portal, and I know a lot of you guys have patient portals that is accessible for both patients and clinicians. Share information such as test results, medication lists, vitals, and other information in the patient's record data. I talked to some physicians, and some physicians have difficulty with putting information on the portal due to the amount of questions they may get from their patients. Now patients can send you a message saying, I don't understand what this means in my report, and then the doctor has to respond to those questions. So they really don't want to put that information out there. Develop a process where many of these questions may go to a clinical staff person first and then to the physician. I can understand what the physician is saying there. The physician will become very overwhelmed with just getting emails, and then while seeing patients, it will be a lot increase to their workload. Identify educational tools such as a flyer, trifolds for logging weight, blood pressure, diabetes logs, and other disease-specific educational materials. A lot of times you can have these things in your portal or on your website, and then patients can actually download these tools and print them. I have one practice that's actually working on trying to log patients' weight so that they can change their BMI scores measures. They actually have them on their website and they're downloading this information, and the patient's using that to log their weight and then sharing it with the doctor the next time they have the appointment. You can also identify credible websites for patients to access educational materials on specific diseases. Use patient engagements to improve your scores. Use of shared decision making by training and ensuring the clinician's team to integrate patient-identified goals, preferences, concerns, and desired outcomes into their treatment plan. You know, a lot of times you'll see a treatment plan with everything that your doctor wants you to do. It would be nice if you want patient engagement, ask your patient what their personal goals are. Is it losing weight? For example, my personal goal is to at least 3 to 4 times a week take a walk on the beach, and that's my personal goal. Whether I get to do that or not, it's a different story. Provide educational tools to the patient. Again, this is any kind of educational material is very good to provide to patients, and treat the patient and their families with dignity and respect. What that means, talk to the patient in words that they can understand, because a lot of times when they don't understand the medical verbiage. Use patient engagement to improve your scores by using a tool to measure patient activation. You know, a lot of times this is hard to figure out, but an example of a tool may be that when you provide a patient a document and where she or he actually logs their glucose level on a daily basis and then brings it into you for review. You know your patient then is engaged because they're actually looking at what they should be looking at. Supporting patient caregiver management of medications. You know, it is very important to have a caregiver or a family member with some of the patients that are elderly when performing medication reconciliation. A lot of times patients don't even know why they're taking so much medication. It would be nice as you're going through the medication reconciliation if you're actually sharing with them why they're taking specific medicines. Here are 2 diabetes educational tools. These they can get off the websites, or you know, you can actually have these tools on your website. You can actually have links to these websites. But here's a blood glucose log, and basically here's a pamphlet on referring your patients to a diabetes self-management program. The state offers this program for free, and they're in the state of Delaware, and are looking for patients to be referred to them. Use patient engagement to improve your scores. Utilization of health literacy patient survey. Again, the Agency for Healthcare Research and Quality defines health literacy as a degree to which individuals have the capability to obtain, process, and understand basic health information and services needed to make appropriate health decisions. They funded researchers to develop variations of a variety of tools to measure an aspect of health literacy. They also suggest that anything should be written and given to the patient should be in a 5th and 6th grade reading capability. Teach back. Because of the literacy capability, you need to actually teach the patient and actually make sure that they understand what you're saying to them, and have them start repeating that back to the clinician. A lot of times, patients walk out of the office and they really don't understand what they should be doing, and it could be any patient at any age group. If they don't understand what they need to be doing as part of their disease process, it's very difficult then to actually see any improvement in your measures. The implementation of a patient and family advisory council. Practice improvement teams and board representatives. Why should you do that? Patients and families, they're experts on the experience of care. They know how the system works. You may think you know how the system works, but they actually know how the system works. Have useful insights and perspectives that are helpful in making practices change and improve. I will tell you that if you have a practice improvement team and you have a patient who has been complaining about something, the best thing you can do is actually invite them on the practice improvement team. You will see things from their point of view that you never saw before. And actually, that will inspire you guys to make the improvement and develop a new process. Another story I have, I was just in my physician's office, where I'm actually seeing transformation happening. I was so glad to see that. I went into a normal office visit every 6 months, and he actually talked to me about what things do you want to see that you want to get accomplished as far as your health. And again, one of my goals, which is to be able to 2 or 3 times a week be able to walk on the beach, also lose weight. So he actually noted that, and that's something that we're going to work on. He also had asked me if I could keep a track of my blood pressure and a log. I mean, that was the first time he ever did that. And he said, your blood pressure is great right now, but I'm only seeing you every 6 months. So if you can keep track of your blood pressure, and if you're starting to have an issue, call me immediately and get into the office. We will see you. So he wanted to make sure that, I actually logged my blood pressure. He did a little bit of training on where the blood pressure should be, and that's what I would be doing on a daily basis. And then if I have problems with my blood pressure, he would then see me at that point in time. I also have a story about my husband. Again, he was one of these patients that we just went through one of the quality measures where his A1C was over 9, and he again was taking medicine, didn't do anything about logging anything or anything like that. He went to a endocrinologist, and he actually talked to him and said, your A1C is over 9, and if you don't keep look at this, you may not be able to see your grandchildren in the future. It ended up, he ended up working with him, having him log his glucose on a daily basis 3 times a day, and now I can say that he's successful, and basically he's keeping it under control. My husband has this has changed him drastically. He's got a really good understanding, and he really loves this doctor because this doctor made a major change for him. So this has been a good thing. Now we're going to go to the third polling question. Kaylin?
Your third polling question is, how has your practice used patient engagement tools to improve any of your MIPS measure scores? Yes, no, or no, but would like to learn more about using patient-driven engagement tools. About 50% voted in. Give it another 10 seconds. Okay, I'm going to close that poll and I'll share those results. We had 36% say yes, 27% said no, and 36% that said no, but they would like to hear more about patient family engagement tools.
Well, I think that's the responses we had is really what I see all the time. I'm glad that we had 36 who said yes. I think patient engagement in the future is going to be really important. I think as us as practice advisors, we need to really be educating our practices on patient engagement. And I think if you don't get your patients involved, you will never see your measures change. They have to be part of the whole process. Now I'd like to go into some tools to use to improve your MIPS score. One of the things I have done in practices is, this is just a ABC practice. This is not good any information for anybody, but this is dealing with a practice who actually are looking at, I think there's 7 measures here, and on a quarterly basis they actually want to see how each of their physicians are doing on those measures. And the reason why they want to compare themselves against their other clinicians is because one clinician may have a better way of doing something, and they want to be able to talk to each other and maybe see how one physician can have a higher percentage on the measure and the other ones do not. So what we do is on a quarterly basis, we actually put it into an Excel spreadsheet and actually come up with a practice average. Because right now, if you're going to be submitting your measures by group, your average is what's going to dictate on what kind of points you're going to get. So you want to be a team here. Your physicians want to be a team. Your practice manager want to be part of the team, and you want to look at this data. You don't want to just submit data and not have a good understanding what kind of what kind of score you're going to get. So if you take a look, controlling blood pressure, you have one that's 91% and one that's 87, but the one of the docs are 66%. So the score, you have to, if you're doing this as a group, you want everybody to actually work together as a team. This is another, and this is a little busy, and I apologize, but this is another quarterly report that you can do. You can actually take your measures, and as you can see, I only have 2 measures on here because you couldn't see it if I put all 6 or 7 of them on there, and actually log based and compare them to the MIPS benchmark. For example, Dr. A, if he was just submitting his, well, he's 0. Let's go to a different one. Dr. B, if he was submitting the measures controlling high blood pressure, he would be at decile 7 because his score is 72.73%. So he would end up getting 7 points for that specific measure out of 10. Dr. C would be getting 8 points, and Dr. D would be getting 7 points. And look at Dr. C. Now, again, we're assuming that they're going to continue to have more patients in this measure, but Dr. E would get 10 points. So wouldn't it be nice to have all of the doctors be at 10 points? So you end up going in and you're doing an average, and of course you do the adds of the numerator and denominator, and the average would be 78.26. So for that particular practice, they would only get 8 points. And I shouldn't say only, that's a good score. Now this is another Excel spreadsheet, which is then looking at, okay, now that we have added up all the positions and come up with an average, what's the points that they would get? So, like for example, on 128 decile 5, they would get 5 points. So you're kind of getting an understanding. You want to get back to the detail as far as what each practice or physician is doing or clinician, and then you want to see if you can do process improvement to improve it. I mean, look at 310, they would get 10 points on that. And the strive is to try to be as high as your benchmarks as much as possible. Plus, it's showing you that you're doing quality care. Now, I did not produce the detail on this particular calculating your MIPS score, but Health Visions Delmarva has an Excel spreadsheet that would help you calculate this, and it feeds it all into this total page. To look at each one of these in detail, you wouldn't be able to see the screen. So it's made up of 3 parts. It's, of course, made up of quality, and basically the quality score is based on some of those charts that you actually saw before, and what we have is in the right-hand side, you would see what your total score would be if that quarter you were reporting it to the government. Then basically we go into the improvement activities, and the improvement activities would be those that's considered 15% of the total score, and you would have those activities, like most of the practices that work with us that have less than 15 clinicians would end up be at 15 points for this, because just participating with Health Visions Delmarva gives you the 15 points. If you're over 15 clinicians, then you only get a medium score. You only get 20 points for a median score, excuse me, and you have to end up adding on 2 other medium scores or projects to actually get the whole 15%. Advancing care is made up of 3 parts. and it's worth 25% of your score. It's made up of a base measure, and you have to do, either, depending on which side you go down, you have to do 4 specific things, and all you have to do is send 1 record over. Or if you're on the other option, you have to do 5 things, and then you send 1 measure over. You have a scoring, like everybody knows that with meaningful use, you used to have a specific threshold to be say you're doing the specific measure. This now is actually looking at a grid where you have, depending upon how many patients you're doing, if it's 10%, if it's 20% or 100%, depends on how many points you get for each measure. Very similar to the quality measure. So you would add them up, and this shows the calculation, and you would come up with, for that specific thing, 68.75. But this would be all behind the scenes. These are some resources that you can use to actually go into. Quality Insights has a great MIPS calculator, and basically you can actually go into their site and download that calculator. If you're working with us, we can actually use our Excel spreadsheet to actually calculate your scores. And I have done that with quite a few of my practices, and basically they're looking at what their score is going to be and how they can improve to make sure their score is as high as it possibly can be at the end of the year. Now, do we have any questions?
At this time, you can either type your questions into the question and chat box provided, or raise your hand and unmute your line to speak live. Okay, Lisa, I'm going to unmute. Lisa, have I muted you? I have Cindy Eisner.
So Barb, this has all been really good information. At the beginning, you were talking about the specifications for the different measures. Is there an easy way for a practice to get a hold of what those specifications are, or did I miss you saying that?
Absolutely. You can go out on the QPP website, and basically you will go down under Education, and you will find a place called 2017 Measure Specification Sheets. Pull that, it will download, and you can actually look for the quality ID number, and whether you're doing it through a quality measure, whether you're doing it through your EHR and your registry, and basically EHR and registry has one thing together, or are you doing it based on you're doing it through your claims. So make sure you pick out the specifications that's pertinent to you on how you're submitting your data.
Okay, great. So I'll go to qpp.cms.gov, scroll down to the bottom on that resources page, education resources, pick the specification sheets, but I want to make sure I'm picking the one for the way I'm going to submit the data.
Absolutely.
Okay, thank you.
I have a question for our practice is thinking of submitting through registry. Where can I find a list of qualified registries?
Again, that's on the QPP/CMS website. You can actually go there, and on the last page, again, the educational information, you will scroll down and you will see a list of registries. Pull up that document and you will see all the registries there.
I'm going to hold the line open for another 5 minutes, so go ahead and submit your questions if you have any. Lisa Saglett's hand was raised. Oh, I'm sorry, she didn't raise it. Okay. All right, at this time, we're going to go ahead and close the line as we're not getting any questions coming through. Today's webinar will be posted to our Health Vision Zomara YouTube channel, as well as the slide deck will be emailed to everyone who attended today. Thank you, everyone, for your time.